Well, welcome to our listeners. I'm Diku Mandavia. I am the Chief Medical Officer for Fujifilm Sonosite. As all of you know, we're in the middle of a global public health crisis with the COVID-19 outbreak. We have areas that are endemic, and certainly Italy seems to be an epicenter at the current moment. And Italy is living through this crisis. And I think it's important for us to learn from the physicians on the front line in Italy so that other physicians can better prepare as we receive these critically ill patients. So with me today, I have a friend, colleague, Dr. Enrico Storti, ICU Director in Milan, Italy. He's also the coordinator for pre-hospital emergency and ICU care there. He's also a pioneer in point-of-care ultrasound and the founder of the InFocus organization. And he's been instrumental in promoting lung ultrasound as well as many other applications for point-of-care ultrasound. So with that as a preamble, thank you, Enrico. I see you're with us from the ICU. Thank you for sparing some time. I think it's really important to get this critical information out. So maybe you could tell our listeners a little bit more of who you are, where you're working, things like this.
Yeah, thank you, Diku, for this nice introduction and for inviting me. It's it's a huge privilege. And yes, I'm a critical care physician, as you mentioned. I've been working in Milan for the last 17 years in Maggiore Hospital, which is a bigger trauma center in the north part of Italy, and also I've been working in the burn units section. And since the last 4 years, I became responsible for the ICU and anesthesia department in Lodi, which is more or less 40 kilometers from Milan. Here I'm responsible for a general ICU with 7 beds originally, let me say, and I will talk about this later. As you mentioned, I am one of the founders of World Interactive Network focused on critical ultrasound, InFocus. So, as you know, ultrasound is part of my life, and I can't see how to run ICU without a probe in my hand. So this is also, another part of my career and part of my expertise.
Very good. We've been reading from the media what's happening in Italy. So tell us in your own words the current conditions in Italy, and then more into the hospital conditions, perhaps.
Yes, as you mentioned before, my ICU, my hospital, has been exactly in the middle of this epidemic outbreak of coronavirus. And let me say that this story has been starting since the last 3 weeks. And in 3 weeks, I promise you, I've seen something that it was absolutely unbelievable until 3 weeks ago, because we have been found ourselves in a mass casualty. This is really the right definition, because we immediately we were forced to face a huge number of patients. I mean, in our emergency department, on an average base, we receive 150, sometimes 200 patients per day in 24 hours. But we receive until 150 red codes and yellow codes with a wave of patients. And all these patients had a severe respiratory distress, IRDS-like, and there was no green or white code. I mean, the minor code completely disappeared, of course. So we were dealing with a huge number of patients at the same time, reaching the emergency department, referring to the emergency department at the same time, but with a severe respiratory distress, and a large portion also of patients who needed to be oxygenated. And this is for the emergency department and for all the hospital has been a huge challenge. We immediately understood that we couldn't cope with a situation like this, where there was and there is a huge disproportion between resources and number of patients, and the intensity, the standard of care that this patient need to improve their condition. And so we were forced to change our hospital rules and to redefine and reshape our hospital, starting from the emergency department, passing through the step-down unit, and reaching to the ICUs. And also, we have been forced to do this without having the chance of make medical transportation of these patients outside the hospital, because all the hospital around in this area are completely overwhelmed by the same number of patients, and even worse. And so we have actually ran a sort of mass casualty.
So it sounds like you, as far as your patient load, you had a disproportionate high acuity group, meaning a lot of patients that needed admission. Can you tell me more about that group, the ages that you're seeing?
Yeah, in the very beginning, the larger portion of this patient was elderly. So 75, 80, 85 years old. And let me say that at that stage, the mortalities in this cluster of patients has been really high, because they had finally a true IRDS with severe severe PO2 FiO2 ratio reduction, and they needed, of course, to be ventilated and to use prone supine strategies, nitric oxide, and so on. But the mortality, was really high. Now, after the last 10 days, 15 days, we see that the average age of our patient is also a little bit lower. So we receive patients with IRDS 40, 45, 50 years old. And this is also another issue, just because that treating IRDS in ICU need an ICU stay, which is very long. So here the problem is not only to create and to enlarge the ICU capability, but also to have in mind that whatever is the number of new beds that you manage to collect, you have in front of you a very long ICU stay. But unfortunately, this virus has the power to infect people is very high, is very consistent, and so there's always a large buffer of patient which is distributed inside the hospital. I mean, in the emergency department, in the other floors, in the other areas of the hospital, completely and fully dedicated to this coronavirus positive patient, which is pressing you, and it's very difficult to imagine how to manage with such a large number of patients with an ICU dependency, which is absolutely important.
So speaking specifically to that, how were you able to surge your ICU capability Did you have enough supplies such as ventilators, monitors, and so forth?
Oh yes, in the very beginning we had a shortage of ventilator, but you know that our Lombardy region, so our welfare department managed to collect and to centralize a large number of ventilators. So finally we managed to have a large number of ventilators. But in the very beginning, I promise you that we have been forced to collect every ventilator inside the hospital, also using the OR ventilators, and to bring also the patient in the OR in order to give them the opportunity to be ventilated, to properly ventilated in a sort of ICU setting. And again, this has been really challenging in the very beginning. Now the situation is, is a little bit more stable. I mean, stable means that we have 24 ICU beds and we have 26 ventilators. So we have the chance to manage this situation. But in the very beginning, also the syringe pumps and whatever is the ICU stuff was completely insufficient, just because we had instruments and also all the ventilators for 7 beds, and now we have 24 beds. And if you think it's important, we can also talk about how we have reshaped the hospital, because not only the ICU and not only the emergency department has been changed to face the situation.
Yes, tell us a little bit about that.
Yeah, I think that this has been a winning tool in this epidemic, because we have been immediately understood that this was a sort of war scenarios, because we had so many patients at the same time, so sick, that we couldn't cope using, let me say, the gold standard. I mean, everybody, every ICU physician perfectly know how to handle, how to treat an IRDS patient. But the problem is when you have to treat 15 IRDS patients at the same time, and when your team is decreased in terms of people able to do the shifts. So this is exactly something which is different. And you cannot use the same tools, you cannot refer to the same guidelines. And let me say that was immediately clear that we were forced to reinvent our way of approaching this patient, and not only our way of approaching the patient, but also how the hospital could assist us in doing this. And so let me say that we have from the day 2, because the day 1 we were completely overwhelmed and astonished about what was going on. But immediately we try to react and to have a different approach. And in this, this has been important in this experience. What we did with InFocus, because that in InFocus we are addicted. We are accustomed to go in critical scenarios. So in people in countries where this disproportion between resources and number of patients, where the healthcare system are very weak, ultrasound did an amazing job, and our experience was important in those countries. And so we reported more or less the same tools. So not referring, for example, for IRDS, the gold standard is the CT scan, okay? But we had too many patients to refer to the CT scan. So we have chosen immediately to treat these patients that were absolutely the same. So severe respiratory distress, PO2, FiO2 very low, and fever and flu in the few days before. So the diagnosis was not so complicated. What was really challenging was to triage these people in the very beginning with something which was very quick, very simple to be done, very effective, and a sort of an all bedside and point of care philosophy test. Otherwise, we couldn't cope. So we managed this patient only with blood gas analysis, chest X-ray, and ultrasound evaluation, of course, of the previous medical history, of course. But those are been have been our pillars to have the final diagnosis and to decide, which is much more important when you have to distribute your resources in a proper manner, where to refer the patient inside the patient, who could stay in emergency department for 24 hours, 48 hours, who should be intubated immediately, and where the patient to refer to the step-down unit. And of course, we have engaged people and redefine the words in our hospital. So we have created a step-down unit from zero, from the scratch, 18 beds. We have, we have erased neurology and the neurology ward, and we put here ventilated patient with a multidisciplinary staff with a pneumologist, intensivist, and everybody who was who had the chance to intubate or to control and to set up a ventilator. So we created a new step-down unit, and we enlarge consistently our ICU capacity. And this is important. This is also very important because, you know, when in coronavirus infected people, you create a ratio which very roughly is, when you create one ICU patient, you create more or less a 5-10 step-down unit patient, and then you have 10 to 20 patients who simply need to be oxygenated. But has been so important the number of patients we receive, that also the oxygen sockets and the total amount of oxygen supply in our hospital has became 5-fold. So we have to ask to the factory who brings here oxygen to refill our oxygen reservoir more than 1 per day. This is only to give you a rough idea about what is the dependency of oxygen for so many patients at the same time.
Wow. Now tell me, besides the oxygen, what other areas do you have constraints on? What other things should physicians anticipate?
Yes, you have to keep in mind that for sure you will receive, if you are in the middle of outbreak. So again, this is our experience because we have been the first ICU to put the right this coronavirus diagnosis in what we call patient 1. Of course, we know now that that patient for sure is not the patient 1. Maybe that the virus was circulating here in Italy or wherever, for sure 15 days before, something like that. Now, I'm not an epidemiologist. This is not my task, but now we have enough findings to say this. And this is something that is important because since the day we receive a number of patients where you have to use 15 liters per minute, and when you have 40 patients, when you have to apply 15 liters per minute, your oxygen delivery in your pipelines are not sufficient. So we were forced also to rebuild the different oxygen sockets inside the hospital and to empower our oxygen pipelines in order not to have a crash in our oxygen system with the consequences that you can simply imagine. So my message is, if you are in the middle of an outbreak, or where the virus is working so actively, you have to be prepared to reshape your hospital and to use techniques that are following the pace that this virus imposed to your hospital. If you try to cope with what we are accustomed to do, for example, CT scan for every patient, immediately ICU recover, prone supine strategy in the very beginning, you can cope because you have not enough nurses to supine 18 patients at the same time. So it's a sort of different triage, and let me say that this kind of triage, which is absolutely not common for Italy, for industrialized countries, is something that is not easy to do. And let me say that also in my team has not been so easy to convince people that we were in a sort of war scenarios, and the only solution was to completely change our way of treating patients, and also to redistribute and to reinvent also the crew, the team, because now we have a team that teams that weren't present until three weeks ago, because now we have different patients in a different location in our hospital with different needs, and with a disproportion between those needs and our ability to catch them.
Okay, so just switching gears just slightly, obviously a tremendous strain on the physicians, the nurses, respiratory therapists, a host of other workers. How do you protect your staff? Have you had many infections within your staff?
Yes, this is absolutely a crucial issue. Yes, you have to protect your staff. You have to protect your staff just because they are your people, but also because when you have an outbreak to face, you have to protect and to avoid that your staff your staff become immediately not sufficient just because they are positive. So luckily we had enough PPI to wear, and immediately we debrief people in order to how to wear and what were the protection strategies for all the team. And that's exactly what we did. And let me say that we had positive physicians and positive nurses, but I do believe that the larger portion of these infected people has been infected when the patient one hasn't been identified yet. So, and also it's not now that that we in Italy we are adopting a social distancing measures, very important measures with a deep impact in our way of living and also in the economic situation of our country, but they are this kind of restriction measures are actually the only solution we have to avoid that the spread of the virus become too important. So we managed to protect ourselves. We had enough PPI, and we managed to do this basically.
Okay, now I know a lot of our listeners would be very curious on what you're seeing on your lung ultrasounds. Anything special or unique to COVID-19?
Yeah, I think that in our experience, let me start from here. This hospital is a hospital with a huge competence in ultrasound. In our hospital, just because we did a very long and very deep job in training people in the last 10 years, because InFocus did an amazing job here in Lodi. And now every single floor of this hospital has an ultrasound machine, or more than one, and all the physicians, so pediatrician, neurologist, surgeons, intensivist, whoever is working here is able to handle a probe and to perform the point of care ultrasound. So point of care ultrasound means to bring the probe in a physician hands and try to assess, to better assess and to monitor the people, and every physician is bringing his own experience in order to decide what is important for patients. So let me say that this is the baseline where we have been starting. But we, just because we were so confident with the point of care ultrasound, and just because all the different teams are fully convinced that this is a huge and a real power tool, we decide to use ultrasound to perform in the very beginning the triage to assess coronavirus lung involvement, and to decide where to bring the patient, and also to treat also the comorbidities, because sometimes we receive young people with only IRDS and or only a lung involvement, from the pneumonitis to bilateral pneumonitis, from ranging from pneumonitis to IRDS. But also sometimes we receive elderly with other pathologies and with other comorbidities. And so ultrasound is also very useful to better assess the patient in the emergency department. And just because, as I mentioned, this at some extent is a sort of worst scenario. You know that ultrasound in where the situation is critical, how this is the message of InFocus, World Ultrasound Network, focus on critical ultrasound. And critical means when you have or a critical situation, just because the patient is very sick, or because you have a very sick patient also in a critical situation, just like we are, because we have very sick patient, but we have also a huge disproportion between resources and number of patients. So ultrasound is clearly the answer. And we did, let me say that also, if I have to compare what we did in this hospital, we have around this area many other hospitals which really collapsed under this sort of tsunami, let's say, sort of wave of patient pushing. They have been overwhelmed and they collapsed just because they they referred themselves to CT scan, waiting for a CT scan report, and waiting for the CT scan be available for the other examination. And this has completely slower and made the emergency department very slow in addressing a large number of patients. And this is something which doesn't work at all. So my experience and our experience, and exactly what we did, is to bring ultrasound quite in the middle of the decisional tree, and this has been really, really effective. So again, for us was blood gas analysis, chest X-ray, and chest X-ray is very important when the chest X-ray is very, very wide, it's a clear positive chest X-ray. When the chest X-ray seems to be negative, ultrasound has a huge capacity to better discriminate if a lung involvement is present, at what extent lung involvement is present, and to perfectly match this lung involvement with for example, with the clinical approach. For example, to decide if we can bring the patient not in step down or an ICU, and the patient was not so sick, we use also the walk-in test. So bringing together blood gas analysis, chest X-ray, lung ultrasound, and walk-in test has been a huge solution to decide who were the patient that was possible to discharge. This is also another issue. If you have no clear where to discharge, when to discharge the patient, and if the patient that you are discharging is addressing to the right place in order to stop the spread of the virus, this is a mess. So ultrasound has been really, really effective in doing such management.
Well, that's been really informative, Enrico. Any other final thoughts or any other advice to physicians that will be listening?
Sorry?
Any final thoughts or any other advice that you may have for physicians that are listening?
Okay, well, let me say that, I mean, here the real answer is to be flexible and to imagine that you have to do something that is not in your background until the day you receive this kind of patient, because the problem is the outbreak, okay, is the virus spread, okay. But what is incredible in coronavirus is the capacity to spread and to create very, very important IRDS syndrome and patients at the same time. So what is unbelievable is that, for example, now I have 24 ICU beds, but in my step-down unit, I know that if you go down now and you go and see what is there, for sure you have other 10 patients to immediately intubate. And here again, there's what is important is to handle the time. Is because you have disproportion between ICU beds, ventilators, nurses, physician, number of patients, and you have to keep them alive until your resources are able to give them an ICU access, an ICU chance. And whatever is the tool that you have, for example, we use CPAP and we use non-invasive mass ventilation extensively. Also, if the PSUF, the PO2 FiO2 ratio is very low, and even if you know that this is not for sure the right way to go, in let me say in a peace condition, when you are in a war condition, you have to keep your patient alive in order to create the right pathway. I mean, treat the sickest and try to free ICU beds, and then bring up the other ones who are waiting in the emergency department or in a step-down unit. So you have to think and to imagine your way of treating patient, your daily practice. You have to reinvent your daily practice and using tools that we are not accustomed to use. Otherwise, if we are too rigid, if you are still rigid in our protocols, we can cope. This is my message. You have to be flexible. You have to know very well your hospital. Another great point is you have to talk with your administrators. You have to talk with your directors, because you have to ask them facilities. You have to ask them to provide staff, and you have to keep in touch with them. You cannot do this is physician issues and no matter other things. You have to talk with administrators, and you have to bring them down and see what is the problem. I brought my CO here and say here in the emergency department and say, okay, this is what we are facing. This is where we are starting from. And we have to cope with that, and we have to avoid to be completely overwhelmed. So I need this. I do not ask you something which is not important now. I'm asking you only what is vital for my patient and for our hospital to survive with our patient. And they understood. And so let me say that also this is important for Italy. Let me say that Italy has, many problems, but here healthcare is a right, is not a service. And here we did, let me say, an amazing job in providing care for everybody, and no matter of financial support. We are struggling with something which is absolutely out of our forecasts. But let me say that the government and our region healthcare system did an amazing job providing things, so very concrete help, but also giving financial support for everything.
Well, thank you. This has been extremely informative. It sounds like you're doing an incredible job under extenuating circumstances. I think in modern medical history, none of us have been through anything like this. Thank you for spending the time with us. I know you're on shift at the hospital. On behalf of everyone at Fujifilm Sonosite, thank you. It's been, again, very valuable. I think our listeners will pick up a lot of pearls that will help save further lives. So thank you again, Enrico.
Thank you so much, Diku, and thank you so much for the support. And as you mentioned, I think that, yes, this is very important. This is very important that our colleagues, wherever throughout the world, knows exactly what may happen. And how to be prepared, how to get ready in time, because we were forced, unfortunately, to reinvent things without stopping the hospital functionality. We managed to do that, but it's not simple. So whoever has 1 week ahead, have 1 week to dedicate to think and to forecast what gonna be the needs. This is a very, very precious time, and I think that whatever we can do to share our knowledge or to share simply what happened to us is more than welcome. Thank you so much for your support and for inviting me.